coronary artery disease, and angina. Atherosclerosis begins as soft deposits of fat that harden with age. They're referred to as hardening of the arteries. Atheromas, or fatty deposits, prefer coronary arteries. Atherosclerosis is a major cause of coronary artery disease, characterized by lipid deposits within the intima of the artery, and the endothelial injury and inflammation play a major role in the development. If you watch my video on coronary artery disease, I go over that in quite detail. Okay, some tests here that we might do on sort of to detect whether or not the person has a coronary artery disease. C-reactive protein is one of them, and this is a non-specific marker of inflammation. So it doesn't mean that you have inflammation in your arteries in the heart. It just means that you have inflammation in your body somewhere. That's the problem with it, is that it might be raised, it might not. But if you can't see any other reason why it's raised and you're suspecting coronary artery disease, this might be a good marker to kind of tell you where that person's at as far as the coronary artery disease process. It's increased in a lot of patients without coronary artery disease, like it says here, and chronic elevations in CRP are associated with unstable plaques. Collateral circulation. Arterial anastomosis, or connections within coronary circulation, increased with chronic ischemia and may be inadequate with rapid onset of coronary artery disease. And like I was talking about in one of the videos that I had made, that the coronary artery disease, if it comes out on a young person quickly, they usually don't have any of this collateral circulation developed. But the more ischemic attacks you have, the more collateral circulation you have developed, because this ischemic tissues release the messengers that stimulate angiogenesis, which means the development of more blood vessels. This is kind of a nice picture here. It shows just like maybe A would be like probably a young person, right? Do not have a whole lot of collateral circulation. And then B is somebody who has had a lot of problems with ischemia, and you can see they've got a lot of plaque buildup there in the artery, and they have developed some ischemia or some collateral circulation. So that process ends up saving them. If you look over on C, where they've actually got the thing clotted off, they have this collateral circulation. Now, they might still have chest pain because they might not be able to get enough circulation through or past that spot, but at least they have some circulation, whereas the poor younger person or the person who has never had ischemia problems will not get any blood past that portion. MP is a 58-year-old white male who visits the local health clinic for a physical examination. He tells the healthcare provider that he occasionally gets indigestion when he mows the lawn. It goes away in 5 to 10 minutes after he stops and rests. So they're kind of setting this guy up for somebody who might have some stable angina, don't you think? When obtaining a health history, what risk factors for coronary artery disease would you ask MP about? Well, for one thing, you definitely want to get some details on the pain. When does it come exactly? Where is the pain? Not pain is right there in the middle of the chest, but referred pain. You can see if it's typical. If it's typical of cardiac pain, and then you want to see, does it always come on with activity, with physical activity, and it always goes away with rest? That's kind of an important factor. And just kind of look at the thing. Well, he's a 58-year-old male. That kind of puts him in the risk area. Ethnicity, family history, things like that. You got a brothers, sisters, parents. What did they die of? Do they have any problems with heart disease? Because at this point, all you know is that he gets this indigestion in quotation marks, quote indigestion quote, I guess is the way to say it. But he says that he gets that when he mows the lawn. So that's all we're going off of right now. So you definitely have to collect this information and seeing what kind of risk factors he's got. So you got the, like I said, the genetic stuff, and you might want to find out what this guy's cholesterol has been, right? Triglycerides, low density lipoproteins, high density, and find out stuff like that. Find out his behaviors, um, what kind of job does he have? Stressful work? Does he have a history of hypertension? Does he smoke? Things like that. Okay, non-modifiable risk factors. Now, there's an important distinction there, modifiable and non-modifiable. And the important distinction is you can't do anything about these ones, right? If they can't change their age, you can't change their gender, at least not where it's going to affect their risk factors, I don't think. They can't change their ethnicity, their family history, genetic predisposition. Those are all things that can put somebody in a category as being at risk, but things that they can't really do much about. Um, so then the reason that this is an important distinction is because when you are teaching somebody the risk factors, you're going to teach them all the risk factors, but when you are trying to improve their life, you will focus on their not on their modifiable risk factors, not this, not the things that they can't do anything to change. So here's the modifiable risk factors, right? So serum lipids, so cholesterol, that is something that you can do something about. It's not real easy, but you can modify your diet. Um, and it's really not as big as you would think as far as your diet goes, because they have found that the most a person is able to alter their low density lipoproteins is like a 15%. So that's not a whole lot, but it is something. So modifying your diet and trying to avoid things that are high in cholesterol uh, is still a good idea. Um, Exercise, though, I'm telling you, exercise is a big thing because exercise can increase your high density lipoproteins and decrease your low density lipoproteins. That's a huge benefit. Does not have to be strenuous exercise, just has to be exercise. You can't be sedate and expect to have great lipid levels. Um, and if you look at the bottom of this slide here. That's go to that site. I always put these things on there. I very seldom actually tell you to do it, but I would suggest that you go to this site here and play around with that calculator, and you'll get an idea of how it works. You might not know what your cholesterol levels have been, so you might not be able to put those in, but you can make something up. Make up a high level of low density lipoproteins, make up a low level, and then just kind of compare them. I've gone there and played with that quite a bit. Look at the difference, and what it is it's a 10-year risk score that it'll give you. In other words, you put all this data in, and it gives you the probability of you having uh, an MI within the next 10 years. And when you play with these numbers a little bit, it really can be quite surprising when you see how much doing things like quitting smoking decreases your risk factor. And these are uh, this is all data that has been collected and statistically valid data, which is what makes this risk calculator really fun to play with. At least I think it is. And then you can look and see now if you can lower your low density lipoproteins and raise your high density. That's another thing that makes a really big difference. If you could change your age, it makes a big difference too. But of course, that's not something that you're going to be able to do. Okay, let's see. Homocysteine level. Well, homocysteine, it's a metabolite when we do not break down methionine correctly or well, when we don't do it well. Methionine is one of our essential amino acids. There's 21 amino acids that we need in order to build all of the proteins in our body that we need. These amino acids, we can put some of them together just with different particles. We can actually synthesize some of them, but there are 9 amino acids that we call essential amino acids, and those are amino acids that we have to ingest. They have to come in the protein that we eat, get broke down, preserved, and then used. And they're called essential because we can't synthesize them ourselves. We have to ingest them. And methionine is one of these essential amino acids. When we take this amino acid in order to break it down, or in order to use it properly, we need vitamin B6, B12, and B9. If we're missing those vitamins, we end up with higher levels of homocysteine. Homocysteine is a metabolite from the breakdown of methionine. With adequate levels of these vitamin Bs, we can break this methionine down and have no problems with it. But when we do have problems and we end up with high levels of homocysteine, it's showed to be very irritable to the intima. Remember when I talked, if you watched my video on coronary artery disease and angina, I talked about you needed irritants, and I named 3 that I just came up with. I named cigarette toxins, low-density lipoproteins, and hypertension. Those are all things that irritate the endothelial cells. And homocysteine is another irritant. So when this is suspected, you got somebody with coronary artery disease, and especially if the person has pernicious anemia, which means that they're lacking vitamin B12, then heck, they're probably lacking B6, B9 also. So they will go ahead and check their homocysteine levels. And vitamin B12, B9, and B6 replacements can be ordered for them, which can decrease the progression of coronary artery disease in a person with high homocysteine levels. Okay, antiplatelet therapy. Well, the problem with when you have angina and you have narrowing of the vessels, you have plaque in there, and that plaque can get small little cracks and ruptures in it, and platelets will stick to it real easy then because you have thrombogenic surfaces underneath the plaque there. And if you take an aspirin a day, it's less likely for that to happen. People that do not have cardiac injury now, they are not recommending. It used to be if you were over a certain age, just go ahead and take an aspirin a day, but now they're deciding no, only if they've actually had problems with coronary artery disease. But anyway, they'll take an aspirin a day, and if they need a little bit more than that for usually other reasons, they might put them on Plavix. Okay, back to MP. MP, his health history and physical exam reveals the following risk factors for coronary artery disease. He's got a family history of coronary artery disease. He smokes one pack of cigarettes every day. He's got a sedentary lifestyle. He eats a high-fat diet. His blood pressure is 152/94, and his BMI is 30.2. And BMI, you can go ahead and take a look. There's BMI calculators on the internet all over the place. I was looking in the Mayo Clinic. If you go to mayoclinic.org, and then when you get there in the search box, put in BMI calculator, you can check your own BMI. And by the way, BMI is body mass index, right? idea of whether or not you're overweight, underweight, or whatever. And normal, it's like between 18 and 25. Yeah, 18 and 25. Based on the presence of these risk factors and MP's complaints of indigestion associated with activity, what type of angina does MP likely experience? Stable angina, right? Or chronic stable angina. Okay, so a lot of times a person with angina will deny chest pain. And when you go in, you'll say, "So how's your chest pain?" They'll say, "I haven't ever had any chest pain." So you have to be really careful of how you word things. They might call them a heaviness, a pressure, tightness, or something like that. A lot of times they will not respond to calling it chest pain. As a caregiver, you kind of think of it all as the same thing because it pretty much is the same thing, but the way they're feeling it is different. So they might feel it as an ache, squeezing, heavy, choking or suffocating sensation, rarely a sharp or stabbing, indigestion or burning. And it could be not in the chest. They might say, "I never had chest pain. I just feel it here in my left shoulder, or I feel it under my jaw." Or, so you got to be careful. This slide here showing some of the different places, common places that people might feel chest pain. All those little reddened areas are right there where they will very often feel the chest pain. And something you want to know too is, does this pain change when they're breathing? They take a breath in, does it make it hurt more or less? Right? Because that can make a difference, and it's usually not cardiac when that's the case. Okay, so this is what chronic stable angina is. You get intermittent chest pain that occurs over long periods with the same pattern and onset and duration. So in other words, it's predictable, right? Every time I cut the grass, I get chest pain. It's right here in the middle of my chest, or it's in my shoulder, or in my, it's the same thing. It happens all the time. And then when I go sit down, after about 10 minutes, it goes away. So that is what it is. Now down here, the duration is usually about 5 to 15 minutes. ST segment depression and or T wave inversion. And I drew some things on here. You can see at the very top up there, I have a PQRST wave there, an EKG. And I just pointed out where the S wave is. That's that downward slope of the big QRS wave. And then the T wave is that big kind of long drawn out slope there that I got pointed to. So if you look down at the bottom, normal is that top one. And right, so normal is this one here. And then if you go to this one here, that there has ST depression. If you look right there, it is depressed, right? And then if you go down at the bottom, they got a T wave inversion, because the T wave, instead of going upward, it's deflecting downward. So those are changes that often affect on somebody who's had long-term ischemic problems. And it is easily controlled with drugs, or usually can be controlled with drugs. Now, there is silent ischemia. There's a person that they might come in and have an EKG done, and you see these ST abnormalities. The person's, no, they've never had any chest pain. It's very often associated with diabetes, because diabetics, they don't feel pain the way everybody else does, because they get damage to their nerves, so they just don't conduct the impulses as well as a healthy person. Nocturnal angina and angina decubitus. Nocturnal angina means it occurs at night, not necessarily while they're sleeping or while they're laying flat. Angina decubitus means every time they lay down, they get chest pain, and it's relieved when they stand up or sit up. Prince Metal's angina. It occurs at rest, usually in a response to spasm or a major coronary artery. So their artery spasms don't have coronary artery disease, right? They don't have a clot in there, but their artery spasms for some reason. These people often are people who have migraine headaches and Raynaud's, because both of those are things that can be caused by vessel spasms. Um, so in this one here, when it's Prince metals, the spasm is in the coronary arteries. Okay, again, let's see. Due to a spasm in the major coronary arteries, may occur with or without coronary artery disease, not precipitated by increased demand. In other words, it's not, they might be just sitting in a chair, right, watching TV, and it'll hit them. Um, chest pain is marked with transient ST segment elevation at the time, right? And transient means that it will come and go with the pain. So usually by the time this person has the chest pain, by the time he gets into the ER, it's usually gone and you don't see that elevation. The medicine that they give, they'll give calcium channel blockers because it relaxes those vessels. With the relaxing of those cardiac vessels, you're a lot less likely to have a spasm, and therefore you're much less likely to have the Prince metals angina. While waiting for diagnostic testing, MP, what drug would you expect the healthcare provider to prescribe for MP to use if he develops the indigestion or pain the next time he mows the lawn? What do you think? What are they going to give him? Sublingual nitroglycerin, right? Put that under your tongue and it will relax the coronary vessels and open them up so that it can increase the amount of blood getting into the myocardium. Okay, the goal, of course, in treatment is to decrease the oxygen demand of the heart and or increase the oxygen supply to the heart. Now, what does nitroglycerin do? It increases the oxygen supply to the heart, right? How can you decrease the oxygen demand? Anything that, if the person has high blood pressure, anything that lowers the blood pressure can decrease the demand because you're decreasing the afterload. The heart doesn't have to work as hard to push into the system. Um, and the medicine, a common medicine to decrease oxygen demand is a beta blocker, right? Because what does that do? It blocks part of the sympathetics, and what it's doing is it's blocking the part that makes the heartbeat hard and fast. So by blocking that, your heart will beat slower and softer, therefore using less oxygen. So you're decreasing the oxygen demand with beta blockers. If you look down here, what are the short-acting nitrates? That's the nitroglycerin I was talking about, and they're talking about the nitro spray or the sublingual nitro tablet. And the way you tell them to take it, if they don't get relief, they may repeat the same dose every 5 minutes, 3 times. Then call EMS if it persists. Call EMS sooner if the condition worsens, right? So you don't sit there and wait, because if you're waiting 5 minutes in between each one of these, that's 15 minutes that you're sitting around doing this. If you're all sweaty, nauseous, and really bad, you can pop one in your mouth, call EMS right away. Right, that's kind of common sense, but you have to kind of tell people that so that they don't wait that 15 minutes if it's really, really severe and different than usual. This is for their normal chronic chest pain that they get every time they do the activity that causes it. So that's when they take it. And EMS, that's a patient teaching. Oh, and they can use it prophylactically. That's what I needed to tell you still. So prophylactically, they can take it before the chest pain. Every time he cuts the grass, he gets chest pain. Well, you know what? Take this, wait 15, sit down. You'll never be up and about when you take a sublingual nitro because it's going to drop your blood pressure. So sit down, take this, wait 15 minutes. So now you've just increased the blood supply and really saturated your cardiac muscle with a good supply of oxygen. And now you can get up and cut your grass, and maybe instead of doing it all in one, do your front yard or cut it in half. You know, do your front yard, take a break, and then do your backyard. However you want to cut it in half. Try to cut the job in half. And like I said, you can take that sublingual nitro 15 minutes before you're going to do it. Okay, so there are these long-acting nitrates. Instead of taking a nitroglycerin every time, you can take one of these usually in the morning, and it kind of acts over the whole day, and they can reduce the incidences of angina. So you can try, they might give them one of these, and like I was saying before, a beta blocker is something that they might give for angina to try to decrease the oxygen demand, and they might give them this here to try to increase the oxygen into the heart. So, to reduce the angina incidence, main side effects are headache. It's not unusual for these people to get headaches, and Tylenol usually works pretty good with them. So and part of the directions is if you get a headache, go ahead and take some Tylenol. They can take it orally. There are nitroglycerin ointments that they can use, and there's the transdermal patches. One of the oral medicines here, and I'm just going to write it down here real fast so you realize this is probably the main one that you'll see. Isosorbide. That's an R. Isosorbide. Right? And you can look that up. You'll be able to find it real easy. But anyway, that's a medicine it's a nitrate, a long-acting nitrate. What diagnostic testing would you expect the healthcare provider to order for MP? Well, let's kind of think about it. Probably a chest X-ray. They want to take a look and see what his heart looks like. Aortic calcifications they can see on there. Pulmonary congestion, if you happen to have something like that. This is kind of one of the base things. Of course, a 12-lead EKG, because they want to look and see if there's any EKG changes. Has he had this to the point where it's changed his electrocardiogram? I always do a CBC too, because you want to look for anemia. Anemia is one of the main causes, or if you have anemia, there's a real good chance that you will get angina because you're not carrying around enough oxygen. Cardiac enzymes, CK, CKMB, and troponin. I probably want to take a look at those. And a big thing on this here is stress testing. They're going to want to, the person gets chest pain every time he cuts the grass. They're going to want to simulate that. Put him on the treadmill and have him walk, or give him a chemical stimulation to stimulate his heart. Make his heart work a little bit harder, and put him and monitor the heart while he's doing it. Because normally, if they have chest pain when they're doing cutting the grass, if they decide to go into the emergency room and have it checked out, they're not having it anymore, right? And the EKG might look normal. They might see the ST depression stuff, but it might look normal. But if you put them on a stress test, you can watch these changes under the condition that has been causing the pain. Okay, this looks kind of like what we were just saying. Laboratory tests. Oh, and a lipid profile. We'd say that on the last slide, but you're going to want to look and see what their cholesterol is doing, triglycerides. An echocardiogram. They'll probably want to do that. See how the heart is functioning. That's an ultrasound of the heart. And with that there, they can see the actual coronary artery disease. A calcium score screening heart scan locates calcium deposits and atherosclerotic plaque in the coronary arteries. Not really anything tough for you to do. You lay down for about 10 minutes. It does this scan, and it will detect any calcifications in the coronary arteries. MP's chest X-ray and ECG results are within normal limits. His cholesterol and triglyceride levels are elevated. Would not be a surprise. Well, let's see what's happening here. He develops chest pain, and ST segment depression during an exercise stress test. Okay, so what additional testing would you expect him to have now? Well, they see this depression, they see this stuff on the stress test. The next thing would probably be to do a cath, a cardiac cath, where they can go in there and actually see the blocks, right? They'll put the dye in, right? They enter through one of your large vessels, usually down in the groin area. I think they're starting to go in the shoulder or arm or something now. They used to go down in the groin area all the time. But anyway, and they will advance this little catheter all the way up into the heart, and they will put dye in there, and they can look on fluoral, which is a type of X-ray that will see this dye, and they can inject the dye into the coronary vessels, and they can see exactly where the blockage is. And if they want to fix it, they can actually go in there and do an angioplasty. They'll put a little catheter thing in there and right up the vessel with a little balloon attached to it, and they'll blow that up, and it opens that up a little bit. And if they need to, they will put a stent in, and that's just a little wire mesh that will hold that artery open after they leave. Cardiac cath and coronary angioplasty. So that's what I was just talking about. You can see the blockages and open them up, and percutaneous coronary intervention. That would mean the balloon angioplasty or the stent. Here's some good pictures of those things. You can see the first one up here, where you've got the plaque, right? So they've got the plaque there, and he's put that catheter right in through there, and then he blows it up. And this here little balloon, this particular balloon has that stent on it, right? And it blows that up, and all these little things lock outward. So it blows it up, and the stent will hold it open. Okay, MP undergoes a cardiac catheterization. A 90% occlusion to his right coronary artery is discovered. He has a balloon angioplasty and a stent placement. Yippee! Sounds like he's going to be a lot better now. Discharge teaching related to the coronary artery disease and necessary lifestyle changes, diet and exercises are provided. He's scheduled for a follow-up with his healthcare provider. So this is where you're going to teach him about nitro and how to take nitro, right? He just had that stent put in, so he's probably going to be put on Plavix or some kind of anticoagulant because they don't want that thing to clot off. Now those stents are treated with something that makes them antithrombotic, but still they like to put them on anticoagulant for a certain amount of time. I think it's like a year that they'll put them on it after they had the procedure done.